Hello everyone. So our lecture today is about the spinal injury. Now I will share my screen. So I will start by making some comments about the spinal cord anatomy, structure, and physiology in order to understand the spinal cord injury issue. So suppose that this is the brain here, and that this is the spinal cord. And suppose that those are the nerve roots coming out of the spinal cord. So those are the nerve roots coming out of the spinal cord. And this is the cauda equina here. Okay. Now, what are the functions of the spinal cord? Actually, there are two types of spinal cord function. There are motor function and sensory function. Those are the functions of transferring data from the brain to the effector. And the other functions are the intrinsic function of the spinal cord itself. So let's start by them. Now, we have motor function, descending fibers, and those include the pyramidal and the extrapyramidal tract. The pyramidal tract is the same as the corticospinal tract, and the extrapyramidal tract, which comes from the basal ganglia to the spinal cord. And there are some ascending tracts, and those include the spinothalamic tracts, the spinothalamic tract, which transfers the pain and temperature to the brain. And we have also the dorsal column of the spinal cord, which transfers the fine touch, the vibration, and the proprioception, the deep sensations. So we have descending fibers, we have ascending fibers. Ascending fibers are the spinothalamic tract and the dorsal column, and we have the descending tract, which is the pyramidal tract and the extrapyramidal tract. So this is the first function of the spinal cord. It's the transfer of data from the brain to the spinal cord. So we have motor function and we have the sensory function. The motor function are the descending tracts, and the sensory function are the ascending tracts. So those are the functions of the spinal cord. We have the motor function. We have the sensory function. And those two functions are related to transferring data from the brain to the peripheral nerves through the spinal cord. So spinal cord function as a transfer medium between the brain and the peripheral nerves. And those are the motor and the sensory functions of the spinal cord. But there are other types of function of the spinal cord which are intrinsic to the spinal cord itself, which those functions are the reflexes, spinal reflexes, and the muscle tone. Okay, we have two other functions. Those are the reflexes and the tone. And those functions, the reflexes and the tone, are functions intrinsic to the spinal cord itself, those functions work independent from the brain. So if the whole brain is not there, the motor function will not work, the sensory function will not work, but the reflexes and the tone are still there. Why? Because the motor and sensory functions are connection from the brain to the peripheral nerve, so those are dependent on the brain, while the reflexes and the tone are independent from the brain. Those are intrinsic function of the spinal cord itself. Okay? So, here comes the next question. What happens if the spinal cord gets injured at this level, for example? What happens? Now, the first question is, what will happen with the function of the segment itself? As you know, the spinal cord is divided into segments. We have 8 cervical segments, we have 12 thoracic segments, and we have 5 lumbar segments and 5 sacral segments of the spinal cord. And from each spinal segment comes out 2 nerve roots on the right and on the left. So each 2 nerve roots, the right and the left nerve roots, come out of the spinal cord segment. So, for example, C6 spinal cord segment, this segment has the C6 right nerve root and the C6 left nerve root. So each spinal cord segment has anterior horn cell from which comes out the motor fibers, and we have the substantia gelatinosa, which receives the sensory input from the peripheral nerve, from the nerve root. Okay? And each nerve root has sensory function called dermatome, which is part of the skin innervated by this nerve root. And each nerve root also has a myotome. The myotome are group of muscles innervated by this specific nerve root. So each nerve root has a dermatome and has a myotome. And those dermatomes and myotomes should be memorized in order to determine the spinal cord injury level. Okay? So here comes the question. What happens with the dermatomes and myotomes which come from the level here above the injury? The level here above the injury, this part of the spinal cord, the level above the injury. In this part, everything works normally. The motor, the sensory, the reflexes, the tone, everything is okay, because this level is not injured. The next question is, what happens with the functions of the dermatomes and myotomes of the spinal segment injured itself? I mean, this segment of the spinal cord, the same segment which is injured. What will happen? For this segment, the motor function will be lost, the sensory function also will be lost, the reflexes will be lost, and the tone also will be lost. Why? Because this segment is injured. And when this segment is injured, then nothing will work in this segment. If it is, if it's a complete injury. Okay, so this is at the same level. When it's complete injury, the same segment has no function at all. No motor function, no sensory function, no reflexes and no tone. The next question is, what will happen with the functions for the levels below the level of the injury? I mean, this part of the spinal cord, this part of the spinal cord. What will happen? This is below the level of injury. This level is not injured, okay? This part of the spinal cord is not injured. So what will happen with this part of the spinal cord? Okay, let's explain that. In this part of the spinal cord, ascending fibers coming from this part of the spinal cord going up will stop at the injured level. So it will not reach the brain. So it will be stopped here because this level is injured. So the sensory function will be lost in this part of the spinal cord. What will happen with the motor function? The descending fibers going to this part of the spinal cord below the level of injury will stop at this level. So the motor function also will be lost. Now, what about the reflexes and the tone in this part of the spinal cord? Actually, the reflexes and the tone are not affected. Why? Because this part of the spinal cord is not injured and it works, it functions normally. There are reflexes, there are tone. This part below the level of injury is not injured. But this part of the spinal cord below the level of injury will be interrupted from the brain. That's why it will lose the motor and the sensory function. Regarding this reflexes and the tone, they are not just normal. Actually, there will be increase in the reflexes, there will be increase in the tone, there will be hyperreflexia and hypertonia in this part of the spinal cord. Why? Because this part of the spinal cord loses inhibition coming from the brain. That's why it will have hyperreflexia and hypertonia. So the part of the spinal cord below the level of injury will lose the motor function, will lose the sensory function, but will preserve the reflexes and the tone, and reflexes will be high, tone will be high, it will have hyperreflexia and hypertonia. Is there an exception? Yes, there is an exception. And the exception is in the acute vis. Actually, in the acute stage, there is something called, if it's complete injury, spinal shock syndrome. What is spinal shock syndrome? Spinal shock syndrome definition is loss of all neurological functions of the spinal cord below the level of injury. Again, spinal shock syndrome is the loss of all spinal cord functions below the level of injury temporarily. So it's a temporary thing. So in this acute stage, in the temporary stage, what will happen? The whole area here will lose its function. So there will be no reflexes and there will be no tone. Okay, there will be no reflexes, and there will be no tone, no motor, and no sensory. After this acute stage end, after the spinal shock syndrome finishes, what will happen? after spinal shock syndrome go away, reflexes will come back and there will be hyperreflexia, tone will come back, but motor and sensory will still be lost because the connection is interrupted. So this is called spinal shock syndrome. Okay? So to summarize, what we said, in the area above the level of injury, everything will be normal because this area is not affected. In the spinal cord segment itself injured, for this segment, there will be loss of everything. Okay? Because this level is injured. The dermatomes and myotomes here will lose everything. For this segment below the level of injury, we will lose motor, we lose sensory. However, the reflexes and the tone will be normal and it will be high, hyperreflexia and hypertonia, except for the spinal shock syndrome, the acute stage, there will be loss of everything. Okay, so this is to summarize what we said. Now, what if the injury is not in the spinal cord? What if the injury is here? This is the cauda equina. Now, when the spinal cord is injured, as we said, below the level of injury, there will be hyperreflexia, hypertonia, and those are called upper motor neuron sign, upper motor neuron sign. Below the level of injury, there will be hyperreflexia and hypertonia. This is called upper motor neuron sign. Now, what is upper motor neuron? Okay. Upper motor neuron starts in the pyramidal cells starts in the cortex. Okay. Starts in the cortex of the motor cortex and end in the anterior horn cell. So this is the upper motor neuron. Again, upper motor neuron start in the motor cortex and end in the anterior horn cell. Now, what is the lower motor neuron? Lower motor neuron start in the anterior horn cell and end in the effector organ, usually the muscle. So this is the lower motor neuron. Now, when the spinal cord is injured here, what is interrupted? The upper motor neuron or the lower motor neuron? The upper motor neuron. That's why, in this case, we will have hyperreflexia and hypertonia. because the upper motor neuron is injured in this case. It is the upper neuron. And hyperreflexia and hypertonia is called upper motor neuron sign. Why it is called upper motor neuron sign? It's called upper motor neuron sign because it results from injury to the upper motor neuron. Now, here comes the question. What if this is injured? It is the lower motor neuron. What will happen in this case? In this case, we will lose everything. The motor, the sensory, loss of reflexes, loss of the tone. And this is called lower motor neuron sign. Why it's called lower motor neuron sign? Because it results from injury to the lower motor neuron. Now, why does this happen? This happens because the reflexes and the tone are the functions of the spinal cord. And when the nerve root is injured, this is distal to the spinal cord. So the peripheral effector will be disconnected from the spinal cord. So the organ will be disconnected from the spinal cord and will not benefit from its functions. So the functions of the spinal cord, the reflexes, the tone, will not reach the effector because the connection is interrupted between the spinal cord and the effector organ because the nerve is injured or the nerve root is injured. This is called lower motor neuron sign. In this case, everything will be lost: the motor, the sensory, the reflex, the tone. In the case of the nerve root, this will be at the level of the dermatome and the myotome innervated by this nerve root. Okay? Now, what if this part is injured? This is called the cauda equina. What is the cauda equina composed of? Cauda equina is composed of nerve roots. So, if this part is affected, all those functions will be lost. There will be hyperreflexia and atonia, and this is called spinal cord spinal. This is called cauda equina syndrome. This is called cauda equina syndrome because it's affection of the lower motor neuron. Okay, so those are the differences between the upper motor neuron and lower motor neuron. Okay. Now, we discussed the spinal shock syndrome. We discussed the spinal cord functions, the upper and the lower motor neuron, what happens in the spinal cord injury above the level of injury, at the level of injury, and below the level of injury regarding motor and sensory and reflexes and tone functions. Now, what about the respiratory functions? So now we will talk about the respiratory function of the spinal cord. As everybody know, the medulla oblongata is the respiratory center is the center of respiration, from which descending upper motor neuron come to the periphery in order to innervate the respiratory function. So what happens? So suppose that this is the head here, this is the head, this is the neck, this is the chest and the abdomen, and those are the legs. Okay, this here, this is the diaphragm. So what are the functions of the diaphragm? Actually, when the diaphragm contracts, it increases the superior inferior diameter of the chest. It pushes the diaphragm downward, and by this, it will push the abdominal content and will result in abdominal expansion. It will result in abdominal bulge. Okay? Again, so the diaphragm, when it contracts, it increases the superior inferior diameter of the chest. It pushes the abdominal content and results in abdominal expansion or abdominal bulge. What is the innervation of the diaphragm? It's the phrenic nerve. It comes from C3, C4, and C5. It will form the phrenic nerve, which innervates the diaphragm. So this is regarding the diaphragm. The other muscle of respiration are, the other respiratory muscles are the intercostal nerves. The intercostal nerves here. What are the functions of the intercostal nerves? They increase the anteroposterior diameter of the diaphragm and result in chest expansion. And those are innervated by what? By the intercostal nerves. And intercostal nerves come from T2 down to T11. So from T2 to T11 come the intercostal nerves. They will result in intercostal muscle contraction, anteroposterior diameter of the chest increasing and chest rise. While the phrenic nerve come from the C3, C4, C5, they innervate the diaphragm, increase the superior inferior diameter of the diaphragm and result in abdominal bulge. So, what happens if the lesion, for example, happen at the C2 level? And it is complete spinal cord injury at the level of C2, for example, here, the C2 level. What will happen? This will result in complete interruption of the respiratory muscles, and usually the patient will have sudden death and will not even reach the hospital. What will happen if, for example, the injury happens at the level of C6, for example? What will happen in this case? In this case, the phrenic nerve is still working, the diaphragm is still working, but the intercostal nerve will stop working. What will happen in this case? Actually, in this case, when the intercostal nerves are interrupted and the phrenic nerve is still working, the chest will not expand, but there will be just abdominal expansion, because there will be increase in the superior inferior diameter of the diaphragm and contraction just of the diaphragm, and there will be no contraction of the intercostal muscles. This will result in abdominal expansion without chest expansion. This is called abdominal breathing. Another name is diaphragmatic breathing. Okay, so this is worth mentioning. Now, what about the autonomic function of the spinal cord? What about the autonomic function? Actually, the autonomic nervous system is composed of the sympathetic and the parasympathetic. The parasympathetic, as you know, come from the cranial nerves and from the sacral nerves. The cranial nerves and the sacral nerves. While the sympathetic nervous system comes from T1 down to L1. This is the sympathetic outflow. Now, there are many differences between the sympathetic and the parasympathetic. The parasympathetic have a specific function, and each function works separately from the other. For example, pupillary constriction works alone, sphincter works alone. So each reflex works alone. This is the parasympathetic. While the sympathetic works all together because it's a response to the danger. This is the sympathetic nervous system. So it works all together. This is the sympathetic nervous system. Another difference is that the parasympathetic is limited in its distribution to the body, just to specific places, while the sympathetic system is widespread all over the body. So the sympathetic nervous system is more widespread than the parasympathetic. Now here comes the function. What is the most vital function of the sympathetic nervous system? Actually, the most vital function of the sympathetic nervous system is the vascular tone. Now, what happens if the vascular tone is interrupted? Vascular tone means vasoconstriction. So when the vascular tone is interrupted, this will result in vasodilation. And this vasodilation will result in hypotension. This is type of circulatory shock. It's called neurogenic shock. So this is called neurogenic shock. Neurogenic shock is a subtype of distributive shock. And distributive shock is a subtype of circulatory shock. Actually, circulatory shock can be divided into distributive, hypovolemic, and cardiogenic, and obstructive. And distributive shock, we have other types. We have also the anaphylactic shock, and we have also the septic shock. Okay, so neurogenic shock is a subtype of distributive shock, which is a subtype of circulatory shock. Okay. Do not mix between the neurogenic shock and the spinal shock syndrome. As we said, the spinal shock syndrome is something different. Spinal shock syndrome is loss of all neurological function of the spinal cord below the level of injury, which will result in loss of tone, loss of reflexes temporarily, while the neurogenic shock is circulatory shock. Now, some books can mix between them, but we want to separate between them. Neurogenic shock is something, and spinal shock is a different thing, although they can come together. Some book can use them interchangeably or can use just one term to express both things. But actually, those are two different things. So this is called neurogenic shock. Now, there can be some details here actually, because as you know, the adrenal medulla is a sympathetic ganglion which secretes epinephrine and norepinephrine in the bloodstream. Now, if the level of injury is above T6, this will result in interruption of sympathetic outflow to the adrenal medulla. And the neurogenic shock in this case will be more severe. If the injury is below T6, adrenal medulla is still innervated and it will secrete epinephrine and norepinephrine in the bloodstream, so the neurogenic shock will be less severe. That's why T6 level of the spinal cord is very important. Now, what is the center of the sympathetic nervous system in the brain? It is the hypothalamus. And there is something called hypothalamus-spinal tract. Hypothalamus-spinal tract, which innervates the autonomic nervous system of the spinal cord. Now, this is regarding the autonomic function of the spinal cord and the neurogenic shock. Another thing which worth mentioning is that the cardiac innervation of the sympathetic nervous system comes from T1, T2, T3, and up to T4. So if the level of injury is above that, this also will result in bradycardia with the neurogenic shock. It can be mixed cardiogenic with distributive, with bradycardia. But if the injury is mid-thoracic, for example, this will result in hypotension without bradycardia. What is the treatment of the neurogenic shock? Vasopressors. It's either selective vasopressor, selective alpha like phenylephrine, or mixed like epinephrine or epinephrine. Now, we will make some comments about the slides. Spinal injury. What is spinal injury? Spinal cord injury is a damage to the spinal cord that results in loss of functions such as mobility or feeling due to traumatic or non-traumatic causes. Sign and symptom can be weakness, loss of motor function, numbness, tingling, which are loss of sensory function, loss of feeling, painful movement of the arm or legs, pain or tenderness along the spine, burning sensation, which is paresthesia along the spine or an extremity, deformity of the patient head, neck, or spine due to the injury of the spine itself, injuries to the head. This is an association with the spinal injury, loss of bladder or bowel control due to loss of the sphincteric function, which is also innervated, and labored breathing with little or no chest rise. This is a result of the abdominal breathing as we discussed. The epidemiology is high, and most of them also are associated with some other injuries like limb fracture, intrathoracic injury, head injury. More than 50% will result in quadriplegia, and it's a main problem actually. What are the causes of the spinal cord injury? There are some traumatic causes and non-traumatic causes. Traumatic causes include car accident, gunshot, falls, etc. And non-traumatic includes polio, spina bifida, fractrix ataxia, abscess, for example, etc., etc. Regarding the traumatic spinal cord injury, most of them are a result of motor vehicle accident, another thing from falls, from assaults, or sport related. Majority due to diving, but the main thing is the motor vehicle accident. Now, the spinal cord does not have to be severed in order for a loss of functioning or to occur. Just a contusion can result in spinal cord loss of function, or just compression or ischemia, for example. The spinal cord injury is very different from back injuries such as ruptured disc or vertebral fracture or spinal stenosis, and here is the difference. Now, when we say spinal injury means injury to the supportive structure of the spine. The supportive structure of the spine means injury to the bone, to the ligament, to the discs, etc. It results in fracture, dislocation, facet lock, and the treatment is reduction, fixation, and diffusion. While the spinal cord injury is injury to the neural element. This results in neural injury, for example. Now, spinal injury and spinal cord injury can come together. How? For example, a fracture happens. This fracture can compress the spinal cord, for example, and result in spinal cord injury. So they can come together. While sometimes one can come alone. How? For example, spinal injury without a spinal cord injury. This happens, for example, if a fracture does not compress the spinal cord. This is a spinal injury without a spinal cord injury. Okay, what about a spinal cord injury without a spinal injury? How can this happen? This can happen, for example, from different things. For example, skiwara in the children. In the children, the spinal column is very lax. It's very flexible. So by some injury, some movement, it can result in hyperflexion. Due to this flexion, the spinal cord is compressed or contused. The spine, because it's elastic, it will come back to its original position without any fracture. So this will result in skiwara, which is called spinal cord injury without radiological association. So this is spinal cord injury without spinal injury. Another example, for example, is the central cord syndrome. This happened in the old people, for example, the old people, the elderly. They have some osteophytes or bone spurs in the cervical spine, and by some movement, when they fall, for example, this will result in hyperextension of the neck, and this hyperextension of the neck will result in the bone spur hitting the spinal cord, resulting in a spinal cord injury without having any spinal structural injury. This is another example. Another example is ischemia, for example. If there is, for example, thromboembolism of the spinal artery, for example. Another example is, for example, polio. So there can be spinal injury and spinal cord injury either coming together or one of them separately. Neurological injuries is not always immediate and may occur or be aggravated only if when there is movement or displacement or fracture or dislocation. So there is primary injury and there is what is called secondary injury of the spinal cord. And the spinal injury can be classified as stable or unstable. In stable, it's not displaced by normal movement, and unstable, significant risk of displacement. That's why immobilization is very important. Now, What is the philosophy of the treatment of any trauma patient? The general philosophy. The general philosophy is to prevent the secondary damage, because the primary damage already happened at the scene. At the time of the injury, the primary damage happened. While our main aim of treatment is to prevent the secondary injury. The aim of the treatment is to prevent the secondary injury. And in general, for example, apart from the spinal cord, when you stop bleeding to prevent injury of the brain and the kidney due to hypovolemic shock, for example. When you fix a fracture, this is to prevent malunion, which is secondary injury. When you, for example, close an open wound, this is to prevent infection, to prevent secondary injury. So our aim of treatment of any injured patient, this is the main philosophy, is to prevent secondary damage, is to prevent secondary injury. Remember this. And this also applies to the spinal cord. In the spinal cord, what are the examples of secondary damage? One of them is mobilization. If there is unstable fracture and you mobilize the patient, this can result in movement of the fracture parts hitting the spinal cord. This is secondary damage. How to prevent this? This is prevented by immobilization. We immobilize the cervical spine by neck collar, and we immobilize the thoracolumbar spine by moving the patient on a rigid board or by log rolling when we roll the patient to prevent this mobilization. Okay? So this is regarding immobilization. Another example of secondary damage which may happen is a result of hypotension and ischemia. Because when there is compression and there is ischemia, there will be further damage. That's why the spinal injury patient should be normotensive, not hypotensive, to prevent ischemia and secondary damage. Another example, another mechanism of secondary injury is the free radicals release. When the spinal cord is injured, there will be a release of free radicals. Those free radicals can cause further damage. We can prevent this free radical damage by giving the patient steroid, for example, dexamethasone or methylprednisolone, but this is controversial. This is controversial to give or not to give. Another mechanism by which secondary injury happens is the ongoing compression. If the spinal cord is actively compressed, if the spinal cord has ongoing compression now, this compression results in ischemia. And the longer the time the spinal cord is compressed, the more ischemia happens, the more necrosis happens, the more damage happens. That's why ongoing compression is considered as secondary injury. This can be prevented by early decompression of the spinal cord. Remember, early decompression of the spinal cord to prevent further damage. So to summarize, what are the mechanisms by which secondary injury happen in the spinal cord? Those are mobilization, we prevent this by immobilization. Free radicals, we prevent this by giving steroids. Ischemia, we prevent this by keeping the patient normotensive or slightly hypertensive. And the one mechanism is ongoing compression, and we solve this by early decompression of the spinal cord. So, in the spine, the structural part, we have bone, we have the disc, and we have the ligaments. And generally, it requires damage to both ligaments and bony column to produce the unstable spine. Principles of the diagnosis and management. Inappropriate movement during examination can change the outcome to worse. That's why immobilization is very important. Mobilization is abandoned only after serious spinal cord injury has excluded by clinical or radiological assessment. And how to take history? You should have high index of suspicion of signs and symptoms, which may be minimum. Actually, any patient of high energy trauma, you should suspect spinal injury till proven otherwise. Every patient with blunt injury above the clavicle, head, or loss of consciousness should be considered as having spinal cord injury till proven otherwise. Fall from height, crushing accident, or high-speed deceleration. Also, you should consider the patient as having spinal injury till proven otherwise. Lesser injuries if followed by pain of the neck, back, and neurological symptoms. So history is to suspect the spinal cord injury or the spinal injury. And remember, look, feel, but do not move the spine. Inspect the head, the face for bruises, examine the neck for deformity, bruising, or penetrating injury. The bones and soft tissue of the neck are palpated for tenderness, bogginess, or abnormal space between adjacent spinous processes, which suggest unstable spine, but after log rolling. So how the patient is rolled, why the patient is rolled, this is part of secondary survey. As you know, A, B, C, D, E, airway, breathing, circulation, disability, then exposure, and secondary survey. In the secondary survey, you examine the patient from head to toe, and part of the examination is log rolling the patient, and you should check his back for any deformity or for any injury. Should carry full neurological examination. You should examine each dermatome, each myotome, and each reflex if you suspect spinal cord injury in order to determine the level of the injury, for example. Remember something, that the spinal cord level injury, this is the spinal cord segment, is not equal to the vertebral body level. Remember again, you know that the spinal cord is shorter than the spinal column. The spinal cord ends at the level of L1. This is shorter than the spinal column. That's why the spinal cord segment injured is not equal to the vertebral body segment. That's why the spinal cord segment is usually more distal to the vertebral body segment which is injured. Remember this. This is very important. Now, for the conscious patient, you examine each dermatome, myotome, reflex, you ask for sensation, you ask the patient to move every joint in order to, and examine the power in order to examine every myotome and dermatome. But what if the patient is unconscious? So there are some features in the unconscious patient which suggest the spinal cord injury. One of them is history of fall or rapid deceleration. This mechanism is highly associated with a spinal cord injury. Head injury is also associated with spinal cord injury. Diaphragmatic breathing, we talked about this. Flaccid anal sphincter, this is part of the spinal shock syndrome in the acute phase. You remember the acute phase, there is spinal shock syndrome, loss of all neurological function below the level of injury. There is everything is flaccid. Okay, everything is flaccid. There is no reflexes, no muscle tone, so everything is flaccid. And part of it is flaccid anal sphincter. Hypotension with the bradycardia, this is neurogenic shock. Pain response above but not below clavicle. This needs explanation actually. As you know, when we examine, for example, for the Glasgow Coma Scale, we examine the consciousness. Part of the Glasgow Coma Scale examination, we give painful stimulus in order to examine the Glasgow Coma Scale. And when we give the painful stimulus, it should be above the clavicle actually. It should be either in the supraorbital notch or clenching of the trapezius or the sternocleidomastoid muscle. Why? Because we need to exclude, in the Glasgow Coma Scale, we are examining consciousness, not the spine. That's why the painful stimulus should be above the level of the clavicle in the sensory innervation of the trigeminal nerve, not of the spinal nerves, because we are examining consciousness, as we said. Here is an example. For example, you are examining Glasgow Coma Scale for a patient. You give a painful stimulus in the supraorbital notch, for example, and the patient, for example, opens eyes to pain when you give the painful stimulus in the supraorbital notch. For example, this is an example, eye opening to pain. This is part of the response in this Glasgow scale. Then you go and you make the painful stimulus in the leg or in the hand, for example, and the patient does not open his eyes when you give the painful stimulus below the clavicle in another place. What does that imply? This implies that the patient has a spinal cord injury, because the patient has a response when you give the painful stimulus above the clavicle, but does not give the same response when the patient is giving the painful stimulus in somewhere below the clavicle. This means that the patient has spinal cord injury. Okay? Now, what about the imaging? Actually, the most important part of imaging for the spinal cord is the cervical spine. Why? Because it's the most common part injured. This is first. And second, this is the most serious, and it can be missed if it's not imaged. It can be easily missed. That's why imaging of the cervical spine in injured patient is very important. What is the gold standard for the imaging? It is the CT scan. Remember, the gold standard is CT scan. Here's a question. A patient comes with suspicion of cervical spine injury. What type of image you order? The type of image is CT, not X-ray. When do you order X-ray? You order X-ray if you don't have CT, just if you don't have the CT. Now, ordering X-ray first, then going to CT, blah, 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 this is historical. This is part of the history. The current guidelines, you order CT scan, not X-ray, except if you don't have CT scan. Okay, so the standard of care is CT scan. Why we don't order MRI at first? Because the acutely injured patient may be unstable, MRI takes long time, the patient may have some contraindication for magnetic field. So we choose the rapid method, which is safe, in which the patient can be easily monitored, which is the CT scan. And also because the bony fracture is more available in the CT scan. More obvious, the bone fracture in the CT scan. Now, what are the indications of CT cervical spine? This is a question. Actually, we use the Canadian rules, the Canadian rule for cervical spine imaging. The Canadian rule say that there are some criteria not to order a CT scan of cervical spine. If the criteria are not met, you should order CT cervical spine. The criteria should be met for you not to order the CT scan. This is the Canadian rule. What does it say? In order not to order CT cervical spine, in order not to order image of the cervical spine, the patient should be fully conscious. The patient should not be under the effect of drug or alcohol. The patient should not have neck pain or tenderness. The patient should not have distracting pain. And finally, if all the conditions are met, you ask the patient to move his head to move the neck in all direction, flexion, extension, lateral bending, right and left, and rotation right and left. And if there is full range of movement without any pain or tenderness, then you can exclude ordering the CT scan. So again, the patient should be conscious. The patient should not be under the effect of drug and alcohol. The patient should not have neurological sign or symptom. The patient should not have neck pain and should not have distracting pain also. Okay, so all those criteria should be met with the full range of movement in order to exclude ordering the CT scan of the cervical spine. When we order image what do we look for? The most important thing is the alignment. You look at the alignment of the spine. For example, you should check if those are aligned together. If every line is aligned together, you also look for the prevertebral soft tissue. If there is edema, and in the open mouth view of the mouth, we or in the coronal CT scan, we also check for the C1, C2 if they are aligned. So the cervical spine injury can result from fall from height, diving accident, motor vehicle accident in which the neck is forcibly moved. An examination, there is abnormal position of the neck, tenderness, pain, and paresthesia. Imaging the AP view, the lateral outline should be intact, the spinous process and the tracheal shadow at the midline. In the lateral view from C1 to T1, open mouth for dentated fracture, but we usually order the CT, not the X-ray. And those are the contour lines where we look for the alignment. Types of fracture, we will start with the Jefferson fracture. This is C1 fracture, C1 ring fracture. This results from axial loading for the C1 ring. This will result in fracture as you see here. And actually there is a ligament which connects the lateral masses, the right and the left lateral masses of the C1 together. This is the transverse atlantal ligament. This ligament prevents the odontoid process from going back to the medulla oblongata. At the same time, it connects the right and the left parts, the lateral masses of the C1. If this ligament, the transverse atlantal ligament, is interrupted, then what will happen? The lateral masses of the C1 can go apart from each other, and we look for alignment here to check for this. And this implicates instability of the fracture. The hangman fracture, it is C2, C3 disc rupture with the C2 pedicle and the C2 pedicle fracture. This is also a traumatic spondylolisthesis of C2 over C3. It results from C2 pedicle fracture or the pars interarticularis of C2 fracture with a rupture of the disc C2, C3. What happens is like this. As you see here, there is a fracture of the C2 pedicle or the pars interarticularis, and this will result in spondylolisthesis of C2 over C3 with the rupture of the C2, C3 disc. This is hangman fracture. And those are the subtypes. Now, the wedge compression fracture, it's pure flexion injury. What will happen? This just the anterior column will have anterior column fracture, which will result in wedging of the vertebra, as you see here. Wedging means the anterior part of the vertebra will collapse, but the posterior part remains intact. This is wedging or wedge fracture. Burst fracture, where there is axial compression of the cervical spine, and this can result in it's a burst fracture. It's a burst of the whole vertebral body, and there can be some fragment which goes and compresses the spinal cord. Regarding the thoracic and the thoracolumbar injuries, the subaxial cervical spine and the thoracolumbar injuries, we have many classifications actually. For example, we have the AO classification, we have the Magarl classification, we have the TCLIS classification. However, those classifications are complicated. As a medical student, you use the Dennis classification. This classification is the easier one, and Dennis actually divided the vertebral column into three parts: the anterior column, the middle column, and the posterior column. Okay, let's discuss this. The anterior column includes the anterior half of the vertebral body along with the anterior longitudinal ligament. The middle column includes the middle half of the vertebral body along with the posterior longitudinal ligament. The posterior column includes the pedicle the transverse process, the lamina, the pars interarticularis, the superior articular process, the inferior articular process, the spinous process, and they also include the ligamentum flavum, the intertransverse ligament, the facet capsule, the interspinous ligament, and the supraspinous ligament. So Dennis said that if you have one column fracture, one column injury, this is stable fracture. If you have two column injury, this is unstable fracture. If you have three columns fracture, this is for sure unstable fracture. Again, now, if the patient has just anterior column injury alone or anterior column fracture alone, this is called wedge compression fracture. If the patient has anterior and middle column fractures, this is called burst fracture. If we have the whole three columns, this is usually fracture dislocation, okay? So wedge fracture, burst fracture, fracture dislocation. This is the easiest way to classify a spinal injury and to tackle whether it's stable or unstable. This is the easiest way. Actually, this is not the most accurate way. We use more sophisticated classification systems in order to determine that. But as a medical student at your level, the easiest part is to use the Dennis classification. So injuries to the spine may be complicated with spinal cord damage, like burst fracture or fracture dislocation, which result in complete transection or incomplete transection. Now, we will start by classification of the types of the spinal cord injury itself. We have what is called complete spinal cord injury. Complete spinal cord injury means that the whole segment of the spinal cord is affected. This will result in loss of all sensory and motor functions at the level of injury and below the level of injury. And we have incomplete spinal cord injury. We have some syndromes like central cord syndrome, anterior cord syndrome, Brown Sequard syndrome, spinal cord injury without objective radiological abnormality. Now, anterior cord syndrome, the anterior part of the spinal cord is affected, and it's usually associated with injury to the anterior spinal artery. What will happen? In this type of injury, the patient will lose the motors and will lose the spinothalamic tract. The dorsal column is intact in this type of injury. So what will happen? The patient will lose the motor function, the patient will lose temperature sensation, the patient also will lose the pain sensation, but the patient will still have the fine touch, the vibration, and the proprioception intact because the posterior column is not affected. Central cord syndrome, actually in central cord syndrome, all the tracts are affected, but the central part of the tracts are affected. And the central parts of tracts, whether sensory or motor, they will affect the upper limb, and this will spare the lower limbs. So what will happen? The patient will have weakness, numbness, paresthesia, loss of sensation in the upper limbs, especially the distal upper limbs, the hands, and the patient will have the lower limbs intact with no problem. This is called the central cord syndrome, and it can result from hyperextension of the neck and usually happens when the patient have some osteophytes in the neck also, in the elderly. Brown Sequard syndrome, it's hemisection of the spinal cord. Hemisection of the spinal cord. In this type of injury, for example, the right spinal cord or the left spinal cord is affected. What will happen here? Actually, the tracts are different, ipsilateral or contralateral, because the pain and temperature is transferred in the contralateral part of the spinal cord, while the posterior column, the vibration, proprioception, and fine touch, and the motor are transferred in the ipsilateral part. So what will happen? The patient in this type of injury will lose the motor ipsilaterally. He will lose the fine touch, the vibration, and the proprioception ipsilaterally, but will lose the pain and temperature sensation in the contralateral part of the body. Spinal cord injury without objective radiological abnormality. This happens actually in the children due to hyperlaxity of the spine, as we said. Secondary injury, as we said, there are some mechanisms: free radicals, vascular insufficiency, ongoing compression, and movement of unstable spine, and we talked how to prevent them. Now, this is very important. Any patient with spinal cord injury should have this chart. This chart can determine the level of injury and can determine the severity of injury, and this chart is very important for documentation of the patient. Now, in this chart, we have the motor, the myotomes here, and we have the sensory, the dermatomes here. And as you see, we examine each level, and we examine the right and the left, the right and the left, the light touch, the pinprick, etc., etc. Regarding the motor function of the spinal cord, we examine for each joint movement, we examine the power. And the power is classified according to a grade from 0 to 5. 0, 1, 2, 3, 4, 5. 0 means there is no movement at all. 1 means that there is minimal flickering movement. There is no full range of movement. 2 means the patient can move full range, but with elimination of gravity, can just move side to side. 3 means the patient can move against the gravity, but not against resistance. 4 means that the patient can move against resistance, but not full resistance, not full power. And 5 is the full power. How to memorize those? The easiest way is to memorize number 3. Then from 3, go up and down. 3 is anti-gravity. Then 4, what is more than gravity? It's resistance. What is above the resistance? It's the full resistance, okay? Now 3 is anti-gravity. Go down 2. 2 with elimination of gravity. 1 is minimal flickering movement. 0, there is no movement at all. And each myotome should be documented by a number from 0 to 5. This is the power. What about the sensation? The sensation, we also examine the deep and the superficial sensation in each dermatome of the body, and we document all of this. Finally, we also should examine the sphincter, because the sphincter is the most distal part of the body. We should do digital rectal examination. Remember, every spinal cord injury patient should be examined by digital rectal examination for the sensation and the sphincteric function, because this is the most distal part. Now, how to do that? The patient should have Foley's catheter. He should be instructed, and the patient should have explanation of what we want to do. He should be on his side. Then, when you start by examining the perianal sensation, and you document how far from the anal sphincter there is sensation, okay, on the right and on the left. Then, after you insert the finger, you ask the patient whether he feels your finger or not. This is sensory. After that, you examine the tone. Is the sphincter hypertonic, hypotonic, or normotonia? Then, after doing this, you examine for the power. How to examine for the power? You ask the patient to contract the anal sphincter. But how? How to examine the patient? How to ask the patient to contract the anal sphincter? The answer is you ask the patient as if he needs to hold himself against defecation. One way is to the patient can imagine himself urinating, imagine himself voiding, then he wants to suddenly stop the voiding. By this, he contracts the anal sphincter. Another way is just to imagine, for example, that he has a diarrhea and he needs to hold himself. By this, he contracts the anal sphincter and you examine the power by this. After that, you examine the reflex. There is a reflex there called the bulbocavernous reflex. Remember, the bulbocavernous reflex. How to do it? There are many methods. The method that we do usually is the Foley's catheter method. You just pull the Foley's catheter gently out. When pulling the Foley's catheter, the ball inside the bladder will hit the neck of bladder. And when this ball hits the neck of bladder, bulbocavernous reflex happens and anal contraction happens. And by this, you examine the reflex of the anal sphincter. So remember, any patient with a spinal cord injury should have this chart. He should be examined for each dermatome, each myotome, each reflex and the digital rectal examination, and everything should be documented at each stage of treatment. The patient should have this chart at admission. He should have this chart preoperatively, should have this chart postoperatively, etc., etc., and at each stage in order to monitor the patient condition. Now, remember that the level of spinal cord injury is different from the level of the vertebral body injury. They are not equal. Remember this. After determining the level of the injury, okay, so when we do this chart, for example, you notice that the patient start losing the neurological function below X level, for example. So this is the level of injury, okay? After that, we should classify the patient according to the assay classification. Assay classification is a classification for the severity of the injury. So assay classification is a classification for the severity of the injury. How is that? We have a classification from A to E, A, B, C, D, E. A means complete spinal cord injury, complete, no motor, no sensation, everything. Every motor and sensation is gone. And when we do this classification, remember, we just examine the voluntary part. We examine the sensation and we examine the voluntary movement. Reflexes are not included in this classification. Remember, reflexes are not accounted in this classification. You just account the voluntary movement, okay? So ACA means complete, no voluntary movement, no sensation at all, even the anal sphincter. E means the patient is completely normal. What about B? B means that the patient has loss of all motor functions below the level of injury. Every motor function below the level of injury is lost. Okay? But there is some sensation. Any part of sensation, the classification changes from A to B. Remember, we examine just the voluntary part. We examine just what is below the level of injury in order to have this classification. For example, if the patient has thoracic injury, for example, you examine the lower limbs, not the upper limbs. This is an example. You should just examine what is below the level of injury. You examine just the voluntary part. So ACA is complete. ACB, you have complete motor loss, but there is some sensation. What about C and D? C and D means that the patient has weakness, but not complete paralysis below the level of injury, some weakness. So you just make like an average of those movements. If the average is 3 and above, this is D. While if the average is below 3, this is C. Here comes a question. Why 3? Why the power 3? Because the power 3 makes a big difference in the disability and the function of the patient. Makes a big difference. For example, if the patient has a power of 3, this means that the patient can stand up. He can make few steps, for example. But if the patient has 2, he cannot stand up. He is wheelchair bound or bedridden. Okay? So this is the classification. Again, NCA is complete motor, complete sensory loss below the level of injury. B means complete motor loss, but there is some sensation. C and D, there is weakness. If the average of the power is below 3, it is C. If the average is 3 and above, it is D. And E is normal. Okay? And those are the clinical syndromes: the central cord syndrome, Brown-Sequard syndrome, anterior cone syndrome. So this diaphragm is also about some sphincteric function. What about the neural control of blood pressure? As we said, there is something called neurogenic shock. Complete lesion above the T will eliminate the sympathetic outflow. Complete loss of sympathetic outflow. This will result in bradycardia also. Lesion between T1 and T6 will preserve the sympathetic tone in the head and the upper extremity, but will deny it to the adrenals and the lower extremity. So the adrenal will be affected and it will be severe, anything above T6. Lesions between T6 and the lumbar cord will preserve the adrenal innervation, but denervate the lower extremity. This means it's less severe because the adrenal medulla secretes some epinephrine and norepinephrine in the bloodstream, and it can somewhat compensate. The spinal shock refers to the acute, this is different from the neurogenic shock, as we said, refers to acute loss of segmental tendon reflexes, muscle tone, and sensation below the level of spinal cord lesion. So it is temporary loss of all neurological function of the spinal cord below the level of injury. In most patients, it persists for 24 hours, but in others, it may persist for long, like 1 to 4 weeks. As the shock diminishes, the neuron regains the excitability and affects upper motor neuron will make their appearance. So after the spinal shock ends, the patient will have hyperreflexia and hypertonia. Okay? After the period of the spinal shock is elapsed. Now, hypotension happens in neurogenic shock, but sometimes, actually, as we said, some books can use just one term to express both. There is something called neurogenic pulmonary edema, which is common in patients with cervical spinal cord lesion, complicating the management. What is the management of the neurogenic shock? Volume resuscitation actually is not enough. Why? Because the main problem is the vasomotor. It's not hypovolemia. So if the patient has spinal shock, volume resuscitation is not enough. It's not the treatment. The treatment is vasopressor. Remember, hypotension and bradycardia will persist regardless of the volume of saline or colloid administered. So you should replace the missing adrenergic tone with alpha agonist like phenylephrine or norepinephrine, depending on the heart rate, actually. For example, phenylephrine is alpha agonist, while norepinephrine is non-selective, alpha and beta agonist. For example, if the patient has neurogenic shock with bradycardia, we prefer norepinephrine or epinephrine. Why? Because it's non-selective. It can increase the heart rate and do the vasopressor effect in the same time. While if the patient has tachycardia with the neurogenic shock, we prefer the alpha agonist. We prefer the pure alpha agonist not to increase the heart rate more. So we use phenylephrine in this case. That's how to choose between phenylephrine, the selective alpha agonist, or epinephrine, the non-selective agonist. What about the cerebral perfusion pressure management? This is very important. So this is developed by analogy to cerebral perfusion. As we said, there is something called cerebral perfusion pressure. There is also something called spinal perfusion pressure. That's why blood pressure is very important in spinal cord injury. We should not have hypotension because this will aggravate the spinal cord injury. This is especially important to be aware about if the patient is undergoing surgery, for example. As you know, most of the general anesthesia surgeries is hypotensive surgery for hemostasis. But if the patient has spinal cord injury, we should do the surgery under normotensive condition, not under hypotensive condition. Why? To prevent secondary damage. Okay? If the patient is normotensive, then the hemostasis is more difficult than the hypotensive. But even though we use the normotensive in order to prevent secondary damage of the spinal cord. What is the general management? Any patient with injury, start with ABC. Okay? If intubation needed, do inline stabilization. Direct laryngoscopy, fiber optic is better to prevent maneuvering of the neck. Okay? Maintain blood pressure with blood volume, prevent secondary injury by log rolling, and consider concomitant head injury if it's there. Methylprednisolone actually is controversial. This is to prevent the free radical damage. It is controversial. What is in consensus is that if the patient has penetrating injury, do not give steroid. If the patient has penetrating injury, do not give steroid. If it's blunt, then it's controversial. Although the current guidelines is against giving steroid at all, because as you know, steroid in spinal cord injury, although they prevent free radical damage, but they also have drawbacks, like in the overall prognosis. For example, the use of steroid can increase the possibility of having thromboembolic disease, pulmonary embolism, because the patient is also bedridden, and they can also increase the rate of infection in those patients. That's why it's controversial, and you should weigh the benefit against the drawbacks. What about the blood pressure? So there is no standard or guideline for blood pressure, but avoid hypotension. The systolic blood pressure should be above 90 millimeter mercury, and it's better to keep the mean arterial pressure between 85 and 90 millimeter mercury in the first 7 days. This is recommended to prevent secondary spinal cord injury by ischemia. Remember, secure the airway, make immobilization, put the neck collar. Those are very important. This is the end of this lecture. Is there any question?